This is Dr. Sargisian, and again, this is a lecture in Genetics in Pediatrics series where we'll talk today about cystic fibrosis. But again, this lecture is part of the Genetics in Pediatrics series, and we will focus on analyzing the relationship between genetics and diseases and facilitating the integration of genetics and genomics in pediatric primary care, including assessment if screening, if applicable. So again, cystic fibrosis is part of the monogenic disorders. Monogenic disorders can be described as single gene trait disorders, and single gene controls the expression of specific structure, protein, or function. So transmission patterns listed here: autosomal dominant, autosomal recessive, and sex-linked pattern. However, the cystic fibrosis is, of course, autosomal recessive. Cystic fibrosis is a monogenic disorder in which both alleles of a gene have at least one mutation, sometimes more, which will lead to problems or issues in transmembrane movement or transport of chloride, basically in and out of the cell. This is, of course, inherited disorder, and the pattern is autosomal recessive single gene trait. This disorder most commonly found among Caucasian population and of Northern and Western European descent. But it can be found at the same time in all races and ethnicities. So in Caucasians in the United States, the incidence of cystic fibrosis is approximately 1 in 3,000 live births, and carrier is much more common, or carrier status. In carrier status, there is only one mutated gene allele, and approximately 1 in 20 to 30 white Americans carries this mutation. So genetic makeup of cystic fibrosis, it's an again inherited gene mutation in both alleles of cystic fibrosis. If it's only one allele, of course, the person will be carrier. And the actual gene is called CFTR gene. It's located on chromosome 7. A gene produces protein, and this protein, the special protein, is serving as a chloride channel and regulates both movement in and out of cells of chloride and bicarb. So also this gene controls some other transport movements or pathways. This is a very large and complex gene. There are many different coding regions. It produces a big protein, and the parts of protein have different roles in human development and actually achieving certain physiological function. So it's interesting that the mutation in CFTR gene can be very, there are a lot of mutation in CFTR gene, and approximately 1,700 mutations are identified. So because of that, because of that many mutations, the severity of the disease may vary. Also, it affects at what age the person will start having symptoms and which organs will be involved. And in spite of the multitude of the mutations, there are still some commonalities, of course. There's a delta F508 mutation. That's the most common one. And unfortunately, it produces the most severe disease. So, as a result of this mutation, the person again has difficulties of transporting chloride and bicarb into the cells. Also, it's interesting to mention that the CFTR mutation, it's not actually ceasing completely the production of this protein, but protein sequence will be altered. So protein functions, but it may be not as effective as protein produced with non-mutative gene. Like I already mentioned, cystic fibrosis is transmitted by autosomal recessive pattern from the parent to a child. So, of course, if you remember that autosomal recessive means that there is some possibility to have unaffected state, affected state, and carrier state. So, remember that affected state will be 50%. I'm sorry, the affected state, so people who have the disease manifested, that will be 25% of offsprings, carriers will be 50%, and those who have no carrier status or no disease, so-called unaffected state, there will be other 25 patterns. And this is, of course, very easily can be demonstrated by drawing a Punnett square. So genetic testing cannot be used to diagnose the cystic fibrosis at this point, but it is diagnosed based on physical manifestations, and actually it's also, there is a fairly definitive test or definitive test, it's chloride test. Positive results show that there is a higher concentration of chloride or sodium chloride in person's sweat compared to a normal value. So the heterozygous carriers cannot be identified with the sweat chloride test because their sweat production is normal. However, genetic testing by direct sequencing of CFTR gene can help to establish carrier status. Also, the affected children can be identified prenatally, and to some degree, the disease severity can be predicted prenatally. Patient with cystic fibrosis will have two main organ systems affected, and this involves epithelial cells. And those organ systems are lungs and pancreas. So epithelial cells in these tissues produce a thick, sticky mucousy substance or mucus because of the impaired chloride transport. And eventually the glands in these organ systems will be clogged, and it will lead to atrophy in these glands, and finally leading to dysfunction in these organs or even failure. So other organs can also be affected, but including liver, salivary glands, and testicle. And most serious complications of cystic fibrosis occurs in vital organs like lungs, of course, and because the patient will have constant thick, sticky mucus, and this leads to airway narrowing and impairs airflow and leads to chronic respiratory infections. And chronic respiratory infections, lower respiratory infections such as pneumonias and bronchitis. Also, the alveolar compliance will be decreased, of course. So patients may also develop lung pneumothorax, arterial hemorrhage, and also may even develop respiratory failure. On the other hand, mucus can be clogging the ducts in the pancreatic ducts, and which will lead to pancreatic atrophy and cyst formation. So pancreas is important for production not only the insulin but digestive enzymes, and of course it's critical to digest fat and protein. And because of that, patient may develop weight loss because of malnutrition. Also, if it's in early age, the child may not develop the height which will be relevant to certain age. And also the short-term consequences, of course, lack of digestive enzymes like lipase will lead to steatorrhea or the fatty diarrhea. Of course, lack of fat in the diet or inability to digest fat will also lead to deficiency of fat-soluble vitamins. So you may ask, what about the insulin production in pancreas? Unfortunately, it also may be affected. However, it will happen in later stages in the disease, and patient will develop diabetes. Liver can also be damaged, and consequently the gallbladder. Salivary glands can dilate, and saliva can be very thick produced. Infertility in a male patient is commonly associated with cystic fibrosis, and it's actually not a true infertility. It's a consequence of undeveloped vas deferens, basically inability to transport sperm from testicles to seminal fluid. So there is no viable sperm available, although person will produce sperm in testicles. So like I previously said, because of the variety of the mutations, that lead to development of cystic fibrosis, there is a variability of disease expression. And the variability in turn leads to different levels of severity and different organ involvement. And so familial history or familial genetic makeup plays some role. And for instance, some patients will, or some families will have more severe pancreatic problems, while others will have severe lung and respiratory problems. On the other hand, some people will develop the disease in basically infant stage, while others will become sick when they are teenagers. And so the latest research also shows that some mutations of CFTR gene can lead no obvious expression, basically, and by mutation I mean homozygous mutation, like both alleles are affected. So the point is that really the expression of cystic fibrosis is very wide, and because of the multitude of the mutations that affects the CFTR genes, and because of that the severity and onset disease may wildly vary. Treatment for cystic fibrosis is mostly palliative. There is no curative treatment, but management of the disease aggressively, such as dealing with lung infections, and can lead to better quality of life and also prolonged life. There is no approved gene therapy for cystic fibrosis, although the attempts were done in the past. The life expectancy is approximately till late 30s, and this is the consequence of improved healthcare management and improved medical therapies. Medications are available, but these are tailored for specific gene mutations. So, and basically location on the gene will suggest if this medication will work or not. So there are two drugs, Ivosactor and Lumacaftor. So these drugs again work on specific mutations. What the pharmaceutical therapy will help with, it's basically the channel opening, the chloride channel opening, and which will help to move chloride ions better through the cell membrane. This is really the main issue, like you remember, in cystic fibrosis. And because if we have the better movement of chloride ions, then the produced mucus will be much more or much less viscous and much less sticky, and it will be basically reduced sodium and fluid absorption. And there are speculations of what really leads to the development of cystic fibrosis, what historical events you can say, or what what the events were when the people start developing cystic fibrosis. And there is a body of research that suggests that heterozygous common mutations in CFTR gene can help to develop resistance to infectious diseases that were quite common in Western Europe and Northern Europe in the past, such as typhoid and cholera. However, this doesn't apply to people who are homozygous and have actually the disease itself, not the carrier status. And this concludes the cystic fibrosis lecture.